Bismillah ar-Rahman ar-Rahim. This is an introductory session for part 3. Congratulations for all my colleagues and my friends who have passed part 3 in the last week. Today I will tell you about, as I used to guide you for the exam tips and tricks, I will tell you about how to pass part 3, why candidate do it from the first time, and why candidate cannot pass part 3. First of all, let's know what is part 3. Part 3 exam is the final step. Part 3 exam assessing your clinical competence. Part 3 exam is a clinical assessment of knowledge and skill, attitudes and competence. Like what? Like the notes. You have the knowledge in part 1 and part 2, and they are sure, the MRCOG is sure about that you have the knowledge. Now, they want you from part 3 how you will apply this knowledge in the practice, how you will deliver this knowledge to a patient. How was your language with the patient? Part 3 assessing or part 3 examination will lead you to gain the member of Royal College. It will be the final touch, the final step of the Royal College. And this is a big honor. They did a great prestige about the MRCOG. Finally, you will be a member. And imagine yourself in the ceremony and taking your certificate, celebrating with all your colleagues which pass part 3. MRCOG is not an easy exam. You need to be well prepared. It's a money-consuming exam. It's a very tiredful exam. The exam time is about 3 hours. You will keep running in the attendance, and you will, at the end, you will feel like you was very exhausted. It's a very tiredful exam, especially in the face-to-face exam. It's not an easy exam. The exam is 14 tasks. 14 tasks covering linked to the 14 module in the curriculum. Each task you will have 2 minutes to read in front of the cubic. I will highlight all this in a presentation. 2 minutes, you will have a notes, you will have a paper, a pen in the attendance face-to-face, and you will write your notes and you will write what you will perform inside the station. If you didn't use these 2 minutes, you will perform nothing inside the station. You will be completely lost. So 2 minutes, 10 minutes, 2 minutes, 10 minutes, and the exam will run like this. 2 minutes in front of the station, and 10 minutes once the bazaar starts, you will enter the station and you will perform. These 10 minutes, you should perform the maximum performance and express yourself, your knowledge, your communication skills, your safety. All this should be expressed in 10 minutes. It's your 10 minutes to use. How to prepare? I will tell you. Let's know what is the 14 module. The 14 module, which is the curriculum of part 3, which will be covered. The first module is the teaching, which we will do it today, inshallah, as an introduction. Teaching, core surgical skills, post-operative care, antenatal, early pregnancy, maternal medicine, labor, delivery, postpartum, gynecological problem, infertility or subfertility module, sexual health and reproductive health, early pregnancy care, gynecological, and the final module is the urogyne and pelvic floor. Today, I will tell you how to perform, what will be the points you need to cover in these 10 minutes, how to pass, how to maximize your effort in these 10 minutes. Usually, part 3 have a 5 domain. The 5 domain is patient safety, which is the most difficult module to cover. Communication, and this is a very important way or a very important module to be taught about it. And I will tell you the secret where the skills of the communication can be reached with the patient and their relatives. Communication with your colleague in a teaching station. Colleague, task, patient, task, structured discussion. These are the types of the station which you will perform. Information gathering and applied clinical knowledge. So the module you need to perform inside, or the assessment will be 5 domain. Patient safety, and will be scored 0, 1, and 2. Communication with patient, again, 0, 1, and 2. Communication with your colleague, like a teaching, or communication with a referral to your colleague in another specialty. And again, if you cover it, you will have borderline or pass or 0. Information gathering, which is the history taking, which is how to perform information gathering, or how to take history from a patient, and how to perform or to understand the background in your colleague task. Also, there is information gathering. Applied clinical knowledge is the last domain, and it will be based upon your background in part 2. So it is not only about knowledge. You need to cover all the tasks. Usually, you have 3 to 4 domains in each station need to cover. So the marks in communication is equal to, in the knowledge, is equal to the information gathering, is equal to the communication patient shift. Each domain have 2 marks. In front of all these domains, you need to cover each domain to pass in the exam. You can fail in one domain only, and still you can pass in the exam. So it's a cumulative assessment for your knowledge, your safety, your communication, and communication with patient and colleague. It's not only about knowledge. Each task will be assessed 3 or 4 domains. So you will never have 5 domains in one station or in one task. Each task will have 3 of these to be assessed, or 4 maximum, no 5. And you need to cover and fulfill the criteria inside the station to take these marks. For example, if you are doing a simulated patient, or you will speak for a patient as you are in the clinic, you will be assessed for communication with patient, information gathering, and applied clinical knowledge, or applied clinical knowledge and safety. Each part of these domains will have 2 marks. If you fulfill the points of this part, you will earn the 2 marks. If you didn't cover all the points in this part or in this domain, you will be in a borderline. If you cannot touch this star point, you will be in a 0. So each domain will be marked from 0, 1, and 2. Each domain will be marked 0 for fail, borderline, and 2 for pass. And each one of these, or each domain of this, let's say the patient safety, will have 4 or 5 points, a star points in the mark sheet. If you mentioned all the points, you will gain the 2 marks in safety. You didn't cover all, even 1 or 2 missed, you will have a borderline. Nothing, so 0 in safety. This is how it's played in part 3, how it will come to pass or borderline or fail. There are 2 types of the task in part 3. A simulated task with patient, or a teaching with your colleague. So you will enter the station, and you will find one inside to act with, either a role player or a colleague simulated patient task, or a colleague task, where you will perform in front of an act, and the examiner will be like a fly in the wall, as they are saying. Don't look for the examiner, will be at the side. So he will test how you will communicate with your patient, how you will communicate with your colleague. And the second or the third task is a structured discussion. Structured discussion, like you are speaking with your consultant. So you will enter the station, you will find the examiner only is sitting. The problem is that you have 14 tasks. About 5 from these will have a lay examiner, not only an MRCOG examiner. So if we focus on the station, the 14 task, you will have 4 structure discussion, 4 communication with patient or simulated patient task, and 5 communication or simulated patient task plus a lay examiner. Why I am telling this? It's a 14 station, 5, 5, and 4, almost 5, 5, and 4, and sometimes they are increased in the lay examiner. If you find a lay examiner, this means this task is critical. The lay examiner will test you in 3 domains: communication with patient, communication with colleague, and patient safety. So this is 6 marks in the hand of the lay examiner, plus the MRCOG examiner or the clinical examiner, which have at least 6 or 8 marks. 8 marks. So in this station, you may face 14 marks. Most of these stations are communication skills. You see how much the communication skills is important for that exam. 5 or 6 stations with lay examiner which have 14 marks. This means this station can pass or fail you in the exam. Once you find a lay examiner inside, 2 examiners, a clinical examiner and lay examiner, this means that you should perform and prove yourself in this station. Marketing, as I told you, it will be according to this criteria. Marketing is carried out at the real time. While you perform, you say the point, you take a mark. You didn't say the point, or you didn't say the topic or the instruction or what expected from you to say, you lose marks. And you will keep gaining marks until the exam finished. The exam is 3 hours without a break. The online only have 10 minutes breaks in between. But the physical exam, there is no break. So it's a very stressful and tireful exam. Let's have a look about this. The simulated patient task, which is a role player like you are in the clinic. You will take care about a role player which will imitate the patient role, similar to that you are doing a task or a player in your clinic. Sometimes you may find that the task outside is different than from the role player. That the task outside the patient is morbid obese and the role player is thin or normal BMI. Don't bother from this, just focus on the task, the instruction outside. The colleague task, which is a teaching station, also it will be marked from 6 to 8 marks because this is a communication skills with your colleague. A teaching station, only one examiner have either 3 domain or 6 domain, so 3 domain or 4 domain, so it will be only 6 or 8 marks in the colleague task, in the simulated patient task. The structured discussion is what Aviva is the other name, which is teaching you or speaking about your knowledge, how to express your knowledge, how to speak or how to communicate with your consultant, and how much you are a safe doctor. And the maximum number of marks will be 6 to 8 marks, either 3 domain or 4 domain. And this is the risky one, which is the stimulated task or patient task. So you have a role player task, which is a simulated patient task, a colleague task, also a role player task, a structured discussion the examiner only will ask you, and you will have the most risky, which contain the lay examiner, the lay examiner station. Examiners are 2 types. The MRCOG examiners or the clinical examiners, which is concerned about your knowledge, and the lay examiner, which can be a bus driver, a worker, any routine ordinary woman from any support group. She's sitting inside the station only to see your language your communication skills, and how you will deliver the knowledge to the patient. If she convinced with you, she will give you the mark. If you are not a good counselor, you will not have the marks. And this is the problem of this station. It can pass you or fail you. Why do candidates fail in part 3? Why it is not an easy exam? It is rarely due to your knowledge. You already passed part 2 and you are a fresh knowledge. Even some of you are better than the examiners themselves. It's rarely due to lack of knowledge, as you already passed part 2 examination. It's always a problem, either the stress, which can affect your exam performance, or you are unable to show the required skills, what was exactly wanted from you or requested from you. You didn't read the task outside. You didn't read the instruction, how to perform inside. How to work in this, how to avoid this. First of all, you need to practice. Practice and an honest study partner is the secret of this exam. Exam stress needs a lot of practice, and try to imitate, especially in the time management, the 10 minutes, which you want to take information gathering in less than 4 minutes, to express the patient concern, to formulate a management plan. You need to have a lot of practice about the time management. The 10 minutes is very important. In this 10 minutes, you should prove that I am a good candidate. A poor skill starts by, a proper skills starts by reading the task in front of the cubicle. If you didn't read the task and you didn't understand what is required from you, you will go inside and tell something else. Sometimes there will be no information gathering, and you will lose about 5 minutes, 4 to 5 minutes collecting information without any marks. It is not requested or required from you. You don't have instruction to take history, and you lose inside, and you want inside and take history without any gaining any benefit, because you didn't read the instruction outside properly. This is how you will see the exam inside, the physical exam. A 14 square, a 14 cubic. Each cubic there will be a task outside, like here. A paper, you will read the instruction, 2 minutes here. You have 2 minutes to read instruction, take your notes, and write what is the important point you want to perform inside. Let's say I will speak about a patient who have BMI, obesity. She is obese. I should address her risk factors. I should ask about the risk of hypertension, the risk of diabetes, the blood pressure. What will be the important points I want to address inside? Screening for diabetes, folic acid 5 mg, aspirin, just points. This will be the safety point inside. So the 2 minutes outside is very crucial if you would like to perform or to maximize your performance. 2 minutes outside reading and 10 minutes to perform the station. So you will prepare yourself and you will imitate your character in these 2 minutes. If you are going to meet your consultant, you will prepare yourself. How I will introduce myself in my consultant. I am Hani, one of the candidates, ready to start the discussion. If you are going to a role player, a patient, you will enter as a doctor. What will be your task? I am Dr. Hani, one of the doctors in the clinic, and you will know the clinic. This is situation awareness. Where are you? At any part. So the 2 minutes outside is very important to prepare your face in a breaking bad news, to prepare your communication skills, your knowledge, your point, how you will enter inside. Okay? And you'll keep running. Actually, there is time loss in between running, and you will avoid this if you are applying online exam. The online exam is spontaneous. There is no running. You will lose about 30 minutes, 30 seconds in each station. So 30, a lot of 30 seconds you will lose to run from here and here. And even sometimes You may run from a room to another room to complete your exam. Running. There is no time to wait in the physical exam. You read the task. Now you will enter the station. You may find inside a colleague, and there is a doll inside, or there is a body, or there is a props. There is a pessary, a cup, there is a forceps. So this is a teaching station. I will communicate my colleague, and the examiner, you will not see the examiner at all. He will be sitting like a fly in the wall. He is assessing your performance. So this will be a colleague, a simulated colleague task, or the teaching task. How many marks in his hand? 6 to 8 marks. 3 to 4 domain. Each domain 0, 1, or 2. The structured discussion, you will enter only with one person inside, which is the MRCOG examiner. Also, he has 6 to 8 marks maximum. It is not a risk station. So I can perform well. It's about knowledge. The communication with your consultant will be tested. The communication will be with your colleague as a multidisciplinary team, or the anesthetist, or the scrub nurse will be tested, and there will be marks on them. The communication with your consultant in front of him will be assessed as you, sir, my consultant, I would like to involve you in the patient of the care, or in the care of this patient. So he will test how you are communicating with him, how you are communicating with your consultant at home, the SPAR tool, how you are involving your senior if there is complication happen. How was your knowledge? Do you have enough knowledge? Are you a safe doctor? So all this, a 3 to 4 domain in a structured discussion. This is the role player, which you will have a 4 or 5 role player without lay examiner, only a clinical examiner. It will be like a patient, the daily task you are doing in the clinic. A patient with PCO, a patient with hypertension, a patient with period, a patient post-operative, and you will speak with her as you are in the clinic. Also, this examiner, the MRCOG examiner, have 6 to 8 marks. This is the most risky task. When you enter, and you will find 3 persons inside. So prepare yourself, please. Don't lose these stations. And in the exam, you will find 4 to 5 lay examiner. This will be the MRCOG examiner, and this will be the lay examiner, which is an ordinary woman, only knows about the patient information leaflet, only knows about a language, simple language, only knows about how you will perform. In her hand, 6 marks, and the MRCOG examiners have 6 to 8 marks. So in this station, you will earn or lose 14 marks. And this which make you pass or fail. 5 or 6 lay examiner stations. Most of the marks, about 75% mark, or 75 marks in these 5 stations. About half of the marks already in this station. Only testing, a lot of communication, a lot of counseling, and usually this will be an anesthesia station which wants you to counsel, how to counsel, how your communication is there. So let's see how we will cover each domain and watch what is needed from me to do. The first domain is information gathering, history taking, and I should be oriented, structured, how I will do information gathering. I should do my template in my background. I should speak spontaneous. I will not lose time to remember. Information gathering in front of the cubicle, there will be the instruction. Is there is information gathering or no? If no information gathering, you will lose 5 minutes from the precious 10 minutes taking history without any benefit. No marks. How to introduce yourself? You should have a template. I used to do like this, to enter the station like this. I am Dr. Hani, one of the doctors in the clinic, and I fixed the template. I am Dr. Hani, one of the doctors in the clinic today. How it's written inside, what is written outside in the task. May I confirm your name and age, please? A first safety point. So you need to confirm the patient name, date of birth. Once you enter, she is the correct patient on that paper or no. What do you like me to call you? A communication skills. What she prefers to communicate. What is your expectation and concern about today's visit? I have read your notes, or I have read your GP, or I have read the midwife letter. What is written outside? Then I will start. If you don't mind, I need to ask you a few questions to know more about you. By the end, I will formulate or I will tell you how things will go forward, and I will give you a patient information leaflet and a follow-up appointment. Is it okay? Okay. A very organized history will help you. So I will start by the introduction, the current history, the obstetric history, gynae history, medical, surgical, family history, social, mental. I will fix my template. I don't have time to lose inside. If I don't have a fixed template, you will be disorganized. So organized structured history is a must. And this is you will gain by practice. A good candidate will use a combination of open and closed questions. And we used to tell this in part 2, how to do a questionnaire, how to start a questionnaire. I should start by open question first. By what? Tell me more about your problem. Is there any problem in your, tell me more about your period. Tell me more about your condition. So I will give the patient the lead to talk, how she will present the problem. This is an open question. A closed question, if the patient proceed to work, to speak, and she didn't stop, I need to close it. I need to target her. When was your last menstrual period? She will answer. Is there any pain? So this is the combination, which is a good way to lead the station. Open question, let her start the speech, let her express her wishes, express her problem, and after that you will take a target questions. What is your blood group? Do you have any concern about blood transfusion? Is there any problem, any bleeding, any pain when it started? This is a closed question. Open question, you are giving her the chance to speak. Like in the current history or history of present tense, the patient presented by what? By pain, bleeding, vomiting. In early pregnancy, patient have pain. Where is the pain? When it started? What increased the pain? What decreased? Is it referred to other side? What do you think is the cause of pain? So this is how I will take history. I will analyze the current complaint in an organized way. A bleeding. What is the amount of bleeding? When it started? Do you feel dizzy? What is your blood group? It may be pregnant. If she is pregnant, so I need anti-D. Do you feel aware about your heartbeat? So I need to know about is it a spots only, a discharge, or more than a period? The vomiting, if there is a complaint like vomiting. So I need to ask when it started, is it related to any food, related to any problem? Is it accompanied by blood? Accompanied, what is the color of the vomit? How many times per day? Is there any abdominal pain? Is there any diarrhea? Any problem in your water work? Any problem in your back passage? This is how I will analyze the current history in any module. So I will tell her an open question. Tell me more about your problem or your condition. There is pain and bleeding started within 2 weeks. When it started, what was the amount? Is it increasing by anything? Is it reduced by anything? Is it referred to any place? So I need to analyze all these. Associated symptoms, waterwork or back passage. You open your bowel easily about the current complaint. Have you ever been pregnant before? Yes or no? What's your fertility wishes? What's your future fertility? You are planning to have a babies or no? It will help in a lot of modules. Any problem so far if she is pregnant? Okay. Did you receive folic acid? What about your blood group in case of early pregnancy and there is a bleeding? Do you have any concern about blood transfusion if you are going to go for OR or you will transfuse a blood for her? So I need, this will be a start point in the information gathering. You need to cover this point to earn the marks of the information gathering. The gynae history, the period, when it start, regular or no, any bleeding in between, when was your last period? The smear in a woman more than 25, is it up to date and normal? Any history of contraception, sexually shared infection, sexual history in case in infertility and coital history is very important. How much frequently? If I ask politely, if I ask about your sexual life, how frequently you have per week? Is there any problem during sex? Any history of sexually shared infection? If I asked, are you sexually active? Is there any problem during sex? In a polite way, because you may lose time. I would like to ask you a few embarrassing questions, but usually I am asking all my patients like this. This is a time loss. We are trying to save the time of history. If I asked, are you smoking? If I asked, do you have any history of sexually shared infection? If I ask, I am not asking embarrassing question. This is their life. So I am trying to get in the point in a polite way. Any problem with your partner? Is there any semen analysis? Is he taking any problem? Is he taking any drugs? Anabolic steroid, testicular trauma, history of surgery? All this will be in the fertility module. Otherwise, are you following your GP? Otherwise, you are fit and well? Are you following your GP for any medical condition? If she said yes, any medication, when it started? When was the last visit to your GP? Any blood test done? So I need to ask if she said any medication. Any surgery which is valid for me and which is valid for the task. Any surgery in your tummy or pelvis or down below, a female genital mutilation. Social history, family history. Any family history of problem or any family concern. Social, what do you do for living? Are you with someone now? Are you in a stable relationship? Is he supportive? Are you smoking? Any recreational drugs? Any alcohol? Everything is fine at home? Here the domestic violence will appear. She will not communicate here. She will stop. And she will say, everything is fine at home. She will lose the contact, the eye contact. She will not look for your eye. She will look upstairs or down or try to avoid the eye contact. So this part is very important as it can highlight a hidden agenda in the physical exam, not in the online exam. The online exam is straightforward, and I will touch it. What is the difference between both? Any drug allergy? Any known allergy before? And this is star point. Always, if you miss allergy, you miss the star point in the information gathering and safety. The psychological and the mental history is an emergency now. So it's a very important to ask about it, especially in a patient who have a history of mental trauma or mental problem or just recent delivery or even have a PCO. All of them need to have a psychological screening. In the last 4 weeks, do you feel low or lost interest in doing things? These are the two questions or the two holy questions in one sentence. All this why? To save the time of information gathering and finish it within 4 minutes maximum. So I can have 6 minutes in the online or about 5 minutes in the physical to counsel the patient. As I told you, there is a time loss while you are changing the station. Running from here to here, it will take about around 30 seconds. So the time to perform the station is not a 10 minutes. It's about 9 minutes. Okay? So I am trying to fix a template with you which will give you a safe time or a safer or a shorter time. In the last 4 weeks, do you feel low or lost interest in doing things? Regarding your history, any things you want to add and should I know? Coming to your concern. Now, I will start the examination and I will start to show my lay language, the patient language. The examination will be in the physical, not in the online exam. No examination on the online exam and no hidden agenda on the online exam. And this is a very important benefit for the online exam. And I will highlight the difference at the end. What is the difference between the physical exam and the online exam and why the online exam is better. Actually, I may need to examine you in the presence of chaperone or if a chaperone, if you don't mind. These are 2 marks. Examination itself as a mark. The chaperone is a star point in safety and a permission. I may need to examine you in the presence of a chaperone if you don't mind. This is how I will ask for the examination. And if I am in a structured discussion also, I will inform the examiner that I will examine her in the presence of chaperone after her permission. It will be a marks. Okay? The examination should be structured. General examination, abdominal examination, blood pressure, temperature, pulse, BMI, height and weight, abdominal examination and vaginal examination. Assessment of VTE, especially in a pregnant woman at booking or at admission, at delivery, labor module, all these are a star points in safety. I will not tell I may need to do investigation. This is a jargon. A blood test is a lay examiner. I may need to do a blood test. Some of our colleagues saying that I will ask my nurse to extract blood from you to send to the lab. 10 minutes to say I may need a blood test. And this is a time loss. You will not have a mark for this. This is not a communication with your nurse. You are not doing this in the real life. And the examiner knows that you are cheating. You are not doing this. I may need a blood test and a scan. So I may need to run a blood test or I may need to do a blood test. I will not order my nurse to extract blood from you to do blood test for you. A time loss. A scan for your tummy or for your womb or to check your tube, to check your ovary. If I need to order a scan, a special test or a special scan. From the examination I have done and the blood test or the history I have taken, I will start to express or I will try to enter the station. And drawing here will help you a lot. Draw and explain in lay language. The drawing is very important in the exam. Let's say you are getting into an ectopic. So you will start by, in a normal pregnancy, usually, this is the womb, this is the tubes, and this is the ovary. the sperm meets the tubes or the egg, the sperm meets the eggs here in the tube. In a normal pregnancy, it travels to stay in the womb, inside the womb. Sometimes it will get trapped in the tube, causing a condition called ectopic pregnancy outside the womb, which may be a life-threatening condition because the tube cannot tolerate the pregnancy for a long period, so it will burst and causes a life-threatening condition, which is a bleeding in your tummy. So drawing will save, and you will have a mark, save time, and you will have a lot of mark to explain this. Okay? Please try to practice with drawing. A lot of marks you are losing in the exam. Instruction or what is option outside. What is the option for the patient? After examination, investigation, or the blood test, after you have a diagnosis, you will go for the knowledge, the instruction. Always remember that wait and see may be an option. In ectopic, there is an option. I will tell her the 3 options. Wait and see, do nothing, medical, and surgical. And I will see the criteria of the station. It can be for medical. I will tell her the benefit and risks. Do nothing which lets the nature to wait or to do its action. And it can be aborted by itself, but actually it may not be for your case if the beta CG is high or there is fetal heart in the tube, so you will exclude. Do nothing which avoids the surgery and avoids the medical treatment. This is her benefit, but you may have bleeding at any time, you may have pain at any time, and may not be the suitable option in certain scenarios. Medical treatment, and if the criteria is met, usually we are offering an injection in your buttock. It will resolve or help the pregnancy to be dissolved or dissolved. It can reduce the pregnancy hormone in your blood, and you will need to be followed up. If the criteria is met, it is not suitable for all women. If the beta CG is less than 5,000, if the sac is less than 3 millimeters, there is no fetal heart. Okay? So the criteria of methotrexate is met, I will offer her methotrexate. No, I will tell her no, there is a fetal heart, or the beta CG level or the pregnancy hormone is much high, more than 5,000, so I cannot offer her the methotrexate as well. I will proceed to the surgery. So these 2 options will not be in your situation. It's not a safer option. Your option will be a surgery. What will be the benefit and the risk of the surgery? So now I will have all the marks of the safety and knowledge. This will be the option. What is your instruction for the patient in a lay language? And here the applied knowledge will appear. Am I clear so far? Do you have any question? I will write back now. Again, I am communicating. I will write back about our agreed plan to your GP, your midwife. And I may speak to my consultant if needed. Not always you need to involve your senior. Like in the clinic, the patient is convinced and everything is fine, you can run a clinic. But if the patient is not willing for or not agreeing with you for a treatment or requesting for a cesarean section, you should involve your consultant. Booking for cesarean section on the patient demand is a consultant decision. So now I need to involve my consultant. How I will close? I will give you the patient information leaflet. I will write back to your GP or midwife, tell him about our agreed plan. I will give you a patient information leaflet. If I missed anything in the counseling, you may find it inside the patient information leaflet. A contact number, a red flag. If you have pain, bleeding, you should come back or call 111 or the 24-hour call number. And a consultant appointment, if needed, you need to involve your senior or your consultant in the next visit. I will inform. Any questions so far? Thank you for coming and close by a smile. Not in a breaking bad news, you will not smile. Otherwise, you will fail in communication. I put a template, and this is my template. You are free to use it. Introduction, a fixed template to cover all the safety point and all the important point. I will post it in the group and it will be free for you if you want to use this template. There is a lot of templates that can use, but just fix your template to own or to try to take these 2 marks and in 4 minutes. There is another way to take history. Yes, and this is the most common used in UK. Another way to take a relevant history. Common mistakes by wasting time asking irrelevant questions, asking closed questions, repeating what you have done, asking twice about the allergy, asking twice about the surgery, asking twice about the medical disease, repeating question, or not listening to the answer of the patient. And this is a failure in communication. The patient is speaking and you are not listening. The patient is vomiting and you are speaking. Actually, you are a rude doctor. You have no ethics. So from where the lay examiner will give you marks? Ignoring the cues from the patient. The role player sometimes try to guide you and you are not here. You start digging for yourself. Anyway, how I will be targeted in the history, there is another way called ample eyes. Ample eyes technique. I taught this in UK. I got teach this from the MRCOG or from the UK courses. Ample eyes means allergy, medication, both medical and surgical, and an emergency, when was the last eat and last drink. Eyes refers to idea, concern, and expectation about today's visit. So remember to ample eyes all the patient. This is the start point in the history. Allergy, medication she is taking, both medical and surgical, which is a very relevant. In emergency, when was the last eat and drink for the anesthesia? This is the ample eyes. Event for which she came for ER. Why you are here? What happened? Tell me more about your problem. Allergy, medication, past history, emergency, when you have your last meal, and why you are here. The idea, the eyes is the ideas. What's your ideas? What's your concern about today's visit? And what's your expectation? What do you want? And remember the emerging family history and social and mental history. So this will be the start point. I need to remember. If the patient pregnant, I need to ask about the current pregnancy and the pregnancy, the past pregnancy. The patient is gynae, I need to know about the gynae history in detail. The current history should be analyzed. Okay, if you have an angry patient, these are the exam tips and tricks how you will pass in part 3. If you have an angry patient, and this is happening, the patient is waiting outside for 3 hours, waiting for your consultant, and your consultant is busy in the ER. So the patient will be very angry, and she will bite you in the station. I am waiting for your consultant. Why you are here? I am very sorry. I understand your concern. I am very sorry, my consultant is little busy or very busy with a patient in the theater. So there is a technique to dissolve the patient anger, and she will calm if you follow this technique. What is this technique? It's called assist technique. Acknowledge. Acknowledge means understand her anger, to take her in your side. Say sorry, because my consultant is away. I know that you are waiting for my consultant for 2 hours. If you don't mind, I can carry the consultation on behalf of my consultant. I already have the notes. I already read the notes. I was involved in your care. So she will start to calm down. Know the story. What was the problem? Why she's angry? Investigate if there is incident report. If there is a problem happen. Ask her, start to find the solutions for the problem and travel with the patient. This is called the assist technique. Acknowledge, say sorry, know the story, investigate, and find a solution for her anger and travel with her in the option and the solution. Okay? If I want to counsel a patient, I want to inform her about how she needs more information, support. There is 5P for counseling. If I want to refer patient for counseling, there is 5P. Anybody knows the 5P? Parent, partner, peers, support group, PC, pamphlet, which is the internet, PC, which is the internet, or the RCOG website, the patient information leaflet, and the pamphlet. So the parent support or the partner support, not in a teens. The peer support group, are people who have the same condition like you. A professional counselor, a pamphlet, a patient information leaflet, and the PC, which is the RCOG site. These are the 5P which you will refer patient for counseling, to know more or to have a support. The lay examiner is waiting for this. Also in a station of a breaking bad news. The lay examiner is waiting for you to show your empathy, your sympathy, how you are breaking bad news. If you are in a station with a Down syndrome, or you are in a station with anencephaly, spina bifida, there is a lot of multiple abnormalities in the patient. How to break bad news? First of all, I need to give a warning shots. First warning shot, second warning shot, and I will start to inform. The first warning say like, you have someone with you. I may have a lot of information to give you today. She said, no, I am fine. Is there any problem with the scan? Actually, I may have some difficult news. Or the ultrasound or the sonographer have a concern about the baby. A second warning shot. There is a hole in the bed. There is a problem in the fetal structure. Or if it is a big issue that the baby will not live, I am very sorry. The ultrasound or the sonographer have a serious concern. I may have some bad or not good news for you. Why? The scan shows that the baby head is faulty making. The pony of the top of the head is absent. This is how I will talk. I will tell a woman about anencephaly. This cannot be tolerated with life. The baby cannot live in his own. He cannot live outside your womb. He depends on you for taking blood or to have support for his life. So first, I will give a warning. The first warning, the second warning, then I will tell her about the problem. And after that, I will keep silence. Give her time to cry or express her wishes. Give her tissue. I can see that you came alone today. Do you have someone with you? I can call a nurse if you don't have someone with you, or a counselor. This may help. I will give you a lot of information. The second warning, that I may have some difficult news, or I may have not bad, or I have a bad news, or I have not good news. So I will tell her that there is a problem. I'm afraid I have got something which is not good news for you. Then I will tell her the scan shows that the baby have a problem, or a serious problem, or the ultrasonographer has a concern or a serious concern, or I will tell her directly about the condition in the scan. And silence. Pause. Respect her sadness. Give her time to cry. Offer her tissue. There will be two cases at the end. Yes, I will discuss teaching stations. One very important station from the recall, and one a teaching station about this. Yes. Then offer her a second scan or show your empathy. Then offer her a second scan about the fetal medicine or ultrasound, another expert to confirm. This is how I would break bad news in fetal anomalies. Also, another problem, if I have a VIN or I have a cancer, a breaking bad news in case of cancer, I will follow the same technique. First warning, second warning, and after that I will tell her there is abnormal cells appear in the smear. The same steps before breaking bad news. Ask her, is there someone with you? I may have a lot of information I will give for you. Signpost, I'm sorry, I don't have good news for you. What's the problem? The scan or the smear or the test shows that you have abnormal cells, which may be a cancer. I may need to have extra tests, a CT, an MRI to confirm. I will refer you to a group of experts to know. Then give silence, pause, respect her sadness, and give her time to cry. This is how I will gather information, how I will earn the 2 marks of the information gathering, how I will break bad news in counseling station if there is any bad news I want to tell, how I will break bad news in cancer. What about the patient safety, which is the most difficult marks? How I will improve. First of all, I need to know about the clinical governance, the never event, the incident report, the triggers of incident report, the patient confidentiality, the quality code guardian, the consent advice. All these are patient safety. I should know about how to take a consent. What are the points? How to take an informed consent. The Mental Capacity Act, the Fraser Guideline, assess the competence before prescribing contraception or termination of pregnancy. The duty of candor, to be honest, the audit steps, the duty of candor, to be honest with the patient in case of complication. How to obtain an informed consent, and this is an essential part, will be tested in part 3 exam. The consent advice is a secret here. If your consultant is away, I need to apologize for them. I would like to take the consultation on behalf of my consultant, if you don't mind. So this is a polite way to know about it. Okay? The female genital mutilation and the safeguarding. Is there any child at home? Is there any hidden agenda? Domestic violence, domestic abuse. Risk management, the never event. Wrong medication, wrong patient, wrong site, wrong surgery, wrong administration of a drug, forgetting a swab, wrong administration of chemotherapy, wrong insulin dose. All these are never event. I need to write an incident report. The WHO checklist, which is a very important part. Even one station, complete station, was on the WHO checklist alone. Part 3 exam could include a structured discussion about safe surgery. One of the structured discussion was about the gynae list. The examiner asked me only alone about the WHO checklist. The whole station about the WHO checklist. We can memorize it together. Prescribing error. If you are going to give a prescription, are thought to be occurring up to 10% during hospital admission by a specialist. Safe prescription of medication is apart from the patient safety. How to improve the patient safety? How to work on it? Review the MRCOG guideline, consent advice, go through and revise the guideline assessing the mental capacity, Lord Fraser, writing prescription, practice writing prescription, how to be safe. Usually you will have a PNF in the exam, so the dose will be with you. The WHO checklist is very important, safeguarding and how you are doing an audit. This is the WHO checklist. a very important safety checklist before surgery. And you should know how to do this WHO checklist. The sign in, time out, sign out. It's a must. One of the tasks in the exam to mention, or the safety point, the start point is the WHO checklist. The sign out, try to memorize the consent, the patient name, confirmation of her identity. If there is any investigation done, how will be the blood loss, any allergy, any risk, any difficulty in anesthesia. So this all will be done before surgery. I should say all the part loud. This is before the woman enters the theater. This is part, the time out before skin incision, and this is before the woman leaving the theater. Okay? Excuse me just a second, I will come back again. So the WHO checklist is a very important part of the safety. I will classify it, or it is composed of 3 parts. Sign in, the sign in, the time out, and the sign out. What is the time in? What is the sign in? What is the time out? And what is the sign out? The sign in is very important, which is to know about the patient, identify the patient itself, the procedure, the consent. If there is any problem during anesthesia, what is the operation itself? Does the woman have any allergy, difficulty in introduction of anesthesia, any blood product needed, any investigation? Okay? Have she received antacid before? So this will be done or be before the patient going to the surgeon. The second part, before skin incision. Before skin incision should be said before the patient to be in the theater, before starting the surgery. If you want to remember it, classify the 3 main people inside the surgery: the surgeon, the anesthesia, and the midwife or the nurse. What is the surgeon concern? What is the anesthesia concern? And what is the midwife wants to do? Everybody should introduce himself by name and rule. This is called the team brief. Team brief. So I am Dr. Hani. I am the consultant doing your surgery today, or I am the ST5 doing your surgery today. And this is Dr. Ahmed, the ST5 or the anesthesia. This is Sister Summer, the one who will assist me. So this is called the team brief. Everybody will introduce himself by name and role. What is the woman's name? Identity confirmed. The obstetrician will be concerned about the surgery, will be concerned about any complication, any extra procedure, any anticipated blood loss. Okay? The anesthesia will be concerned about the machine and the RASA score of the patient. Is it difficult intubation, obese, any extra procedure needed, what will be the time of the procedure? This is my concern as an anesthetist. The scrub nurse need to see what? The instrument, the equipment, the surgical site infection, the blood test, the ultrasound, the urinary catheter, the fetal scalp fluid in case of cesarean section. So this will be my concern as a scrub nurse. The sign out after the patient going to surgery or going out from the theater. What was the procedure? Any complication happened? Any equipment issue? The operative detail should be written here as soon as possible. The post-operative care of plan, antibiotic, painkiller, DTE, analgesics. If the sample taken, this sample is labeled or no. The anesthesia, if there is complication, any concern about the recovery, and the midwife accord the blood sample. So I should know each component composed of what. One of the station was about this only. The gynae list, the examiner only asked about each single point in the WHO checklist to see that you are aware about it or no. Okay? I have two lists, one for gynae and one for maternity. This is one for maternity where there will be the cesarean section, category 1 or 2 or 3, and the baby. The pediatrician informed or no. The placental site. The baby blood group or the baby label or the cord blood sent or no. So this will be the modification between the gynae list or the gynae WHO checklist or the maternity and cesarean section. This is how we will prescribe or how to write medication. One of the station, he will give you a prescription. He will handle you a prescription to write it. So you should know if the patient have allergy or no. No allergies. Write on the paper the patient number, the NHS number, or the file number, the patient name, address, date of birth, the code for her, indication for the treatment, notes for general pediatrician or general practitioner, the follow-up, the drug, a clear, illegible writing. Like HRT, you are writing HRT, pause in a station on HRT. What is the dose? For how many? What is the specific? You are giving tablet or a patch. The dose, the route, the direction, for how many? And I will do all this. If there is paracetamol, if there is antibiotic, I will write the name, the dose, the route, oral, rectal, patch, injection, and direction for how many days, instruction, and if there is any duration or any increase or reduce tapering dose like this. And after that, I will write the name, the clinic, the specialty, consultant note, the contact number, the date, and I will sign and I will stamp. This is the formal filling. Patient name, date of birth, age, the consultant, the hospital, the treatment, the dose, for how many, signature, date, stamp, and the NHS number or my number. You will fill this in the exam. One of the station also there was OSAT. He will give you the paper of formative OSAT. You will give a feedback for your candidate. So you will fill the paper in the exam. If you are not aware about the paper, you will not read in front of the examiner. You will not have time. You should know about this before. Okay? This is how to cover the most important point in patient safety. Communication with patient, the secret of this is to active listening. Be an active listening for the patient. Ask her about her concern. Communication with patient and family need to listen for the patient and tell her to express her wishes. Ask her about concern. You need to know the patient information leaflet by heart because this will improve your communication. This is the secret of exam. And I will tell you, communication is two-way process. Involves listening and giving advice for them. So you need to active listener for the patient and answer her concern. Information, a good starting point is breaking ice by listening to the patient idea and concern and expectation. Give the information as a short task, a chunks, not a lecture. Give the patient a chance to start the task by what? By open question. Explain her ideas and concern and expectation. Be active listener, eye-to-eye contact and open posture. This will be the physical exam. Body language is very important in the physical exam. Okay? If you listen for the patient and you are going in a wrong direction, she will start to bring you back in the proper way. Sometimes it's really important to ask the patient about her concern. If you are deviated from the task, she will ask, I don't want surgery, doctor, I just want to know about the medical treatment or the conservative treatment. So she will bring you back to the marks. So that's why it's very important to ask the patient. Your lay language. Most of us will speak in a jargon. How to improve the lay language? The lay language is the patient language, the ordinary man language, or the ordinary woman language. The patient information leaflet. The patient information leaflet will guide you for the communication, will guide you for the proper important point for the patient, will guide you for the most important patient safety. All this in the patient information leaflet. Patient information leaflet, patient information leaflet, patient information leaflet. If you want to pass this exam, save it by heart. And I will tell you, if you open the patient information leaflet, use this highlighter in it. You will see, I will tell this information if you have ectopic pregnancy. I will inform him about normal pregnancy first. So I will start by the normal thing, then the abnormal thing. How I will tell her, what will be the important point, what will be the option, how I will diagnose it. If you follow the stepwise in patient information leaflet, you will pass the exam, because it is done to counsel or to give information for patient. What is the common mistakes? Sometimes I will forget to introduce myself. Some candidates forget to introduce themselves in the exam. Stress. Or feeling embarrassed about asking about the social or the lifestyle or the sexual life. No, you should ask. If I ask, are you sexually active? Any problem during sex? Telling the patient that what they need rather than negotiating. This is called a patronizing effect. I am telling you what you will do. You should do. No, it's not like this. She will refuse, and she has the right to refuse. So you need to have an agreed plan, negotiation. You should win the fight, not order here. Patronizing is not accepted at all by the lay examiner. If you didn't listen, you will not complete the task. You will miss. So you need to involve the patient. Not listening to the patient or respecting her wishes or views. That's why you will not have the lay examiner mark. You will not have the communication mark. Or using a lot of jargon or abbreviation. The patient does not understand this. She needs a layman language, a routine language. How will be the marks for communication with your colleague? First of all, your colleague may be a midwife, an ST1, ST2, or a consultant, or the blood bank, or the anesthesia. So all this will be marked as a communication with colleague, a pediatrician. In case of labor, a preterm labor, who will be informed? The anesthesia, the pediatrician. In case of blood transfusion, the lab, you need to inform the lab, you need to inform the blood bank. This is how they will mark for the communication with colleague. It's not only the GP and the midwife. The safety will be for your colleague in the task, and you should mention this colleague in the task. Referral letter for the GP and the midwife and the clinic letter is a communication. Your communication with the consultant, the SPAR tool, situation awareness, background assessment and recommendation. A structured way for communication, especially in the labor ward, virtualization, the handover. The multidisciplinary team, the consultant, the role of multidisciplinary team and the role of consultant, and your colleague, the teaching task, a step-by-step process. Don't ask him something you didn't inform. You didn't teach him about it. So you will fail in communication with colleague. Teach him first, then start to tell him about hands-on, or tell him to repeat after you. What will be the common mistakes here in communication. Not adopting a logical, reasoned approach in the clinical decision making. You are not justifying why you are calling these people, why you are in need for anesthesia or a blood bank. Struggling to have or to convey a clear summaries. Failure to use a structured system like the SPAR tool in handover or communication with your consultant at home. A very effective tool of communication. Situation awareness. I am Dr. Hani in the labor ward, speaking to you about a patient who have symptoms and signs of preterm labor. Background. Assessment. I have examined her. She have a frequent abdominal contraction 3 per 10 minutes. Her abdomen is tender, her blood pressure, pulse temperature, and her VE examination is about 3 centimeters. I recommend to give her betamethasone and what? Glucolysis. Until now, I will not give magnesium sulfate after 4 centimeters when she is in established labor. This is how to inform my consultant about a case of preterm labor. A SPAR tool. Proper writing, legible writing, operative note, we will speak about it in details. How to write a clear plan of care, how to refer to your colleague in another clinic, how to involve the multidisciplinary team. You are not working alone. You should work within the team. The applied clinical knowledge, and this is what you have already. Already you passed part 2 and already you have a lot of knowledge. You need to emphasize on this knowledge, update it, and try to tell it in the station. We need to review the summaries again, the charts, the guideline, the evidence-based practice, the WHO checklist. You need to justify your action. Why you are doing this? I am doing full blood count because of the patient looks anemic. I am doing urine analysis to exclude urinary tract infection in patient of preterm labor. And they like this approach. You should justify your action. Why you are requesting this. Okay? If you fulfill this criteria, you will have the marks. This is an example for a mark sheet. An examiner mark scheme. If you tell this point in communication with colleague, you will have the 2 marks. If you missed 2 or 3 of them, you will have 1 mark. If you didn't say, you have the 0. Especially in safety, you see how many points of safety? If you tell all these points, you will have the 2 mark. If you missed only 1, you will have borderline. If you missed half of them, you will have 0 safety. You are unsafe doctor. Communication with colleague, professional approach, encouraging the trainee, clear, concise instruction, check the knowledge before telling them, avoiding or repeating them, teaching the skill first before asking about any skill. Check the learning background. Ask him if he will do a procedure. Are you a right-handed or a left-handed? This is apart from the information gathering in the colleague task, and nobody knows about this. Check the knowledge. Did you hear about this before? Shoulder dystocia. Did you hear about operative vaginal delivery? Did you hear about neonatal resuscitation? Forceps? No. Can I know why you want to know about it? Are you a right-handed or a left-handed? This was a start point in the information gathering, and nobody knows about this. Let's move to the safety. I should fulfill all this to have the 2 marks of the examiners. Correct indication, contraindication, evacuate the bladder, using anesthesia, choose the technique of the instrument, which is an instrument, the bladder empty or no, a start point in safety. A big mark was on this. The correct application, use of the forceps or the ventouse, rotatory or non-rotatory, waiting in between contraction or you are doing without contraction, episiotomy, postpartum hemorrhage, Risk of oasis, third and fourth perennial tier. If you missed 1 point only, you will not have the mark. You will have 1 point. That's why most people fail in safety. So you should cover all this to have the 2 marks. Apply clinical knowledge. This is the relevant indication. Why? Justify indication, contraindication, complication, how to apply, when to stop, when to halt, when to remove. So this is what will be in the mark sheet. An example for the mark sheet. Let's go for the tips which ensure that you have to pass this exam. Patient information leaflet. Patient information leaflet is your way to pass. If you want to pass this exam. Record, even if you don't have a study partner, record by your voice in your mobile and keep listening it in the car. Keep listening your voice, repeating the patient information leaflet. You will speak spontaneous. Even if you don't have a study partner. Record the station. And listen, study in the car, study in the theater, study in the labor ward, study everywhere 24 hours. You will have the language, you will have the proper knowledge, you will have the safety point, the communication skill, all in the patient information leaflet. Don't panic. Your attitude will be judged in the exam. Don't be afraid. If you lose the station, you can recover it again. Don't panic. Read the question in front of the copy. Otherwise, you will not know what is requested from you. Body language, this will be a very critical point in the physical exam. Listen for the role player, active listening. Drawing. Look on the table if there is proofs and use it. I will teach you this today. In the pessary, on the table, there is a cup, a jar, like the jam jar, a pessary and a lidocaine gel. So he didn't put this for nothing. There is proofs in front of you. There is a pelvis and doll. So you should use this and teach and ask your colleague to do it after you. After you teach him, can you tell me how to do this? And I will tell you how to do this. Drawing is very important and the lay examiner is waiting for you to draw. Don't point in yourself. This is non-professional. If you are telling that chest pain, don't point on your chest. If you are doing neck swelling, don't point on your neck. Unprofessional technique. You should be professional. Some of us doing this. Be nice and friendly and have a smile except in breaking bad news. This is rudeness. Practice, 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 practice. Even if you don't have a study partner. Just record the patient information leaflet by your voice and listen it in the car, in the theater, in the street, in the market. Online courses will help you. Yes, it will help. It will save a lot of time. And you will have a professional feedback. Some students studied together and they don't have an official or a professional feedback. This is the benefit of the online courses. Yes, it will guide you, it will save time, and you will have an honest professional feedback. Recalls, 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 recalls. Again and again and again and again. Even if there is a twist in the station, you will read all the relevant data about this question or about this station, as we did in part 2. And the last thing is look after yourself. Dress professional. If a man, dress a tie. Have a suit and tie. If a woman, dress professional. This will be my advice for you for who will go in the physical exam. Because usually in the next exam, if you are applying in your country, Egypt, Shanghai, London, or I think Singapore, I posted the announcement in the group, you will have no option for the online exam. You will attend physical. Okay? If you are in a country that there is no physical, this now you will have an option for the online exam. Why the physical exam is a little bit tricky or difficult than the online exam? I told you before about the period of running and missing the station. In between running, you will have an effort and you will lose time to run between station. And even in one of the exam, I ran from a room to another room. So this is a time loss. It will not happen in the online exam. Just a click after click, a screen after screen, so no time loss. You have to worry only about the internet connection. The benefit of the online exam also that you will not have a visa, a money issue, financial trouble. You will not travel. You will not have a tickets. You will pass in your room with your family. Only 3 hours you will sit on the desk in front of your computer and you will pass the exam. Wow. A lot of money saved, a lot of effort saved, a lot of time saved, visa issue, traveling. What else? There is no hands-on the online. There is no forceps. There is no instrument. This will be in the physical. So you will not do hands-on technique. The teaching will be like a paperwork, operative notes, discharge summary, CTG. There is no ventouse. There is no instrument. There is no surgical steps. It will be only teaching on paper, like the CTG, the discharge summary, the referral letter, the operative notes. I will give an example today about this. So this will be the benefit. So you will have a time benefit, financial benefit, a time benefit in between running. You will have less stations, which is some station cannot be performed online, which is the hands-on, the instruments, the surgical steps. Most of these hands-on, the note tying, all this will not be performed online. So there is no hidden agenda. There is no domestic violence. There is no any hidden agenda in the online exam because it's difficult to pick it online. And the instructors will tell you that freely or frankly in front of the exam. The exam is straightforward. There is no hidden agenda. What in front of you is in front of you. A very important point. So what will be the difference between the online exam, the Osler's online exam, and the physical exam? This will must be the most important difference. For me, it's an opportunity to pass part 3, the online exam. It's a big chance. A lot of benefit actually from the online exam. Okay? You will have this file before your exam by about 2 weeks. Preparing for your online Osler's exam. First of all, he will send you a check. How to check? You need the requirement. What is the document for? On the day of exam, the last thing you won't issue about the internet. You won't issue about contact information or check your process or check the video or check the streaming. So you will check it. Is it working on your computer or no? Some of the countries have unstable internet. One of my friends wants to a company to have a stable internet to do the exam. In Gulf or in Egypt, I think you will have the requirement. It's about 1 megabyte, 1.5 megabyte download and upload. So you will have. What happened actually in the exam? They told, remove your phone. I speak, I'm sorry, I may have sudden internet drop or electrical shutdown. I will keep it in the room, but away from my hand. So if any internet drop, I will shift my laptop to the mobile internet. He said, yes, but you will be seen. Your hand should be on the table or in the desk while you are performing. So if you have an internet issue, you will have your mobile in the room, but not in your hand, in a silent mode, just to use the mobile internet. Okay? and you will depend on the laptop battery. You don't need a head or a wireless phone. It should be a wired headphone, or the computer or the laptop speaker itself. So the requirement for Osler: check the IT system, checking your browser, checking the speed of download and upload of internet, and a contact information. If the internet drop, you will call, or you will use the phone internet. Checking your IT. The NHS laptop and networks will not open the Osler, so you cannot do it from your work. Even in Gulf, if you use the hospital network, she will block the Osler. You give access. You need to give access. So up-to-date browser, you need a Windows or MacBook operating system, a Google Chrome up-to-date, and working webcam and a microphone. If you are using a headphone, it should not be wireless, because there will be a break in your voice. It should be a wired, with a wire. Okay? About the internet, it should be 1.5 upload and 1.5 mega download. And you will test the camera, and you will test the voice before the exam. So you will be relaxed about your computer or IT issues. For your exam, you need a stable internet connection. A wired connection will be better. Wi-Fi, if it's okay. The minimum requirement for the exam will be 1.5 upload and download. There is a mobile for testing your speed. I did it before my exam. If you want to test it, your speed internet, you can test it. The upload and download. How to check your band. How to check it. The NHS Wi-Fi or the hospital Wi-Fi will not work. So try to do it at home, not at the hospital. It's only 3 hours at home and you will be fine. What you will expect in the exam day. Before you start, you will have a chaperone. He will speak with you and give you a debrief about the exam. Please make sure you have completed all the check outline. Your webcam, your voice is clear, and your internet is stable before. And the chaperone will appear for you. This is your voice, picture. This is the chaperone or the role player will appear a big screen like this, and this will be the examiners, a lay examiner or the RCOG examiner. The internet signal strength is here. Your microphone, you need to mute or unmute here. The brief notes, if there is another notes, you will press here and you will have the notes if you want to write your notes. 4 here, view and hide the notes. 5 is the number of stations. This will be of station 1. Then when you move, the station will move. 1, 2, 3, 4, 5 until 14. And there is a break in the middle. And a very important benefit from the online exam. Time is in front of you. So you have the control on the time management. It is not available in the physical exam. The time here is counted from 10 to 0. So you need to take history in 4 minutes. If you exceed this, know that you are losing the station. So you can fasten your rhythm. Your rhythm can be increased or slowed down according to the remaining time in the station. A very important benefit. If you have an issue, something happened, don't touch it. Just if the internet connection or lose the connection, if you touch it, you will refresh. And this is the full screen. Refresh the page, you will lose all this. Don't refresh if you are in the exam. Don't play with this. Don't play with the button. Refresh button, he will refresh the program and you will lose all the connection. So keep your hand away from this button. And look out, you will lose the exam. So don't touch this button at all. This refresh the page and you will lose all the connection until the program reload again. And if you logged out, you lost the station or two. So you need to be here only. If you have an issue, touch this. If there is no issue, don't touch it at all. Otherwise, you will lose the exam. The chaperone will chat with you here. There is a chat history. This one. Are you okay, Hani? Yes. If you want to go to the bathroom, you write here in the break, I want to go to bath. Okay. You have 2 minutes to go. After that, I came. Okay. The chaperone will speak to you. The chaperone will see you, but you will not see him. He will see you all the exam time. He will speak with you before, and he will be seeing you all the exam that you are not opening something or you are not having any electronic device with you. This will be the instruction which you will expect in the exam or on the exam day. And you will keep 2 minutes. The task will appear here. After the 2 minutes, the task will appear and this role player will be big screen. So you need to focus and concentrate on the role player. Okay? So 2 minutes will be reading the task. After that, the task will disappear and the role player will be big here and the examiner will be small. Don't focus with the examiner. Focus with the role player. We believe that every part of the medical exam should be held honestly and with a high standard. The exam is recorded and you will not lose a time running. It's immediately. The paper will disappear, the instruction, and if you want to read any paper, you will press here, the paper will appear on the side here. If you want to go back for the instruction or to see anything, you can. You can from these notes here. Okay? Then you will perform 10 minutes in front of the role player. After that, you will run 2, 10, 2, 10, 2, 10 until the 3 hours finished. And this will be, there is a very benefit here that in the middle, after 7 stations, you will have a break about 10 minutes. There is a break. A smooth process. Log in, the waiting room, reading time 2 minutes, 10 minutes, and you will not log out unless the chaperone tell you that your exam is recorded and you have performed the 14th station. So he will tell you now you can log out. I confirm that your 14 tasks have been recorded. A very smooth way for the exam. Okay? Logging out, he will tell you, don't log out until I will tell to log out. Because there is sometimes an issue in a station, you will have a rerun again. 1 or 2 stations which is not recorded, or the examiners have loss of connection, or you have loss of connection. So you may repeat 1 or 2 stations at the noon time or the afternoon time. Okay? This will be the pre-exam briefing or the chaperone. Will speak to you. I am your chaperone. I will be with you for the whole exam. If you need anything, just raise the hand or write in the chat here. I want to bring you. You can have some snacks and you have a clear water on the table. Otherwise, you should not have anything on the table. If you want to call me, either raise your hand in front of the camera or write in the chat box. He will appear for you. Otherwise, he will disappear. He will be monitor you only. The reading time will be like this. This is the instruction, and you will have a countdown timer for 2 minutes. So you have a control on the time. A very important notes. And the notes will be here. If you want to add or write notes, there will be a paper for the notes appear on the screen. So you can write the BMI, the blood group, the weight, any instruction, the counselor, anything you think that it will be an important in performing the station, you can write it on the notes. Okay? So the time management is controlled here. After the reading 2 minutes, automatically the paper will close and the chaperone or the role player will appear. The examination room, when you enter the examination room, you will have to see both the role player and your examiner. The role player automatically has the big screen. So focus on it. Don't think about here. Any examiners, it will be like a fly in the wall. But there is something I want to tell you here. If you have two examiners here, means what? This is the station I want to perform. I want to counsel. This is the lay examiner which will pass or fail me. The 14 marks tasks. And this is the chaperone. So just look if you have two examiner or one examiner to perform perfect or to counsel perfect. Okay? And you try to do that in all stations to perform your maximum. This 10 minutes to prove yourself. And there will be a smooth way. 210, 210, 210 until the 3 hours. If you have any internet issues, you will have a rerun. He will tell you before you close, you have a missed station, you will have a rerun. At this time, you will come back again to do the rerun. 1 or 2 stations. I didn't have a rerun. Okay? Once the examination is finished and you complete, and the chaperone will tell you that your exam is complete, now you can log out. When you see this message, your exam finally finished, and all, I waited for about 1 hour, almost 1 hour, until this message appeared. You see, 3 hours exam and 1 hour sitting in front of the screen waiting for a rerun. Don't leave or shut down unless you have the message and the chaperone tell you now you can log out. Okay? Clear? So this was the tips and tricks for the exam. And what is the difference between the physical and what is the difference between, or what is the benefit? Of course, the benefit of the physical and the online exam. Any question until now? If you want to practice, write your name in the chat and I will call you.
Shall I, sir?
Okay, start, my dear.
Hello, I am Monicam, one of the ST5. Shall I know may I know your name?
My name is
Your
Hani.
ST1.
I am the new doctor here. I am the ST1.
Hello, Hani. How do you find the postings here?
Actually,
How
I
the
find
colleagues
it very, very nice. The department is very supportive and all people here very cooperative.
good to hear. And if you have any difficulty or any problem, you can approach us. We seniors are here to help you. Hani,
Thank you.
I came to know that you wanted to learn about pessary insertion. How did you develop this interest?
Actually, I was in the clinic yesterday with my consultant, and one of the patients came with a prolapse, and I was embarrassed that I don't know anything about pessary or type of pessary, how to put it, when to remove it. I was embarrassed to ask. So my consultant asks me to come for you and speak about the details of this pessary.
Shall I start our discussion so that we can learn together? And if I'm not clear, you can stop me at any time.
Okay, thank you.
Shall we start? This the pessary here, this ring-like thing, no, round. That one is the pessary. This is called as ring pessary, and it is flexible. It is made up of polythene or polyvinyl polyderm. have you have seen the insertion, no? Before, what do you know the indications of pessary insertion?
No, I never read about it.
They are usually insertion is being done for women who are waiting for surgery of prolapse or women who are pregnant with prolapse or women who are not willing for surgery and who are not fit for surgery. These women will be opting for pessary insertion, and this ring pessary is can be used in women who are sexually active, who are menstruating. There are some other pessaries are also there. Um, they are called as shelf pessaries, which can be used in women who are postmenopausal or who are not sexually active. Am I clear so far?
Yes, yes. So I have a lot of type of pessary. How I will decide the type of pessary?
The ring-like one is called a ring pessary. The one with the middle portion will be obstructed with a protrusion. That is called a shelf pessary. One will be in a rectangle like with a mild elevation. That is called as a Hodge pessary. There are so many types. I will show you on some other day. And with the if I show, then it will be very useful for you. Here we are having only the ring pessary now. Um, so before telling, we have to explain to the patient about the pessary, and we should get her permission from. First, we should greet the patient, introduce ourselves by name and post, and we should take her permission to examine and check her name and age, and in presence of chaperone, after asking her to void urine and ask her to lie on the couch in a good um, privacy, providing privacy in the presence of chaperone, we can do the bimanual pelvic examination to find the size of the pessary. We can do by introducing our uh, index finger. That is the distance between the symphysis pubis to the sacral promontory. So this is the uh, diameter of the pessary. Am I clear so far?
Yeah, I couldn't use it. They gave me the jam jar. Why I will use this or how I will use this?
This will be first we have to lubricate it with the gel which is provided. This numbing gel, that is the lidocaine gel. You should ask before check for allergy. You should have a targeted history from the patient. If she's having some latex allergy, we should not use the particular glove. We should use silicone gloves like that. The this we should give you some importance, and she should not be allergic to lidocaine. Then after application of this and explaining to the patient the procedure, we have to give pressure to the uh, ring pessary that will become 8 like this as it is shown here, no? So then we can introduce it in front of the vagina and slightly push it, and then the posterior part will be kept in the upper part of the posterior fornix, and this anterior portion will be kept underneath the symphysis pubis as far high as possible. If you do like this is lifting the vault of the vagina up. Am I clear so far? So it is
Yes,
lifting
yes.
above the pelvic floor, it is lifting. So it is not coming down. And we should inform the patient that it may take 1 or 2 trials to have the adequate size, and we should ask her to walk around to go for toilet to empty the bladder and come. If it becomes if she feels some discomfort or if it comes out, she should come back. Am I clear?
Yes,
Uh,
yes. So after I
can
put
you?
the pessary, I should tell her to walk for 15 minutes.
Uh, where should the posterior end will be? Can you repeat?
So after
The
I put it the
ring
pessary,
pessary.
I will ask her to walk for 10 to 15 minutes and pass
Yeah.
urine.
Yes. After that, if she is okay with this, she'll be advised to come after 6 weeks, or if any problem arises at any time, she develops any discharge, false smelling discharge, or any pain, if it comes out, or if she feels some discomfort, she can come back. And sometimes she may need another size pessary may be required. Most of the women become better with this. They have good response with this pessary, but it is a transient method, and they should change once in 6 months. Otherwise, what will happen? It may get buried into the vagina. It can get adherent, and some stone-like thing may form. Some fistulous tract may also form. So they have to be informed well, and we have to explain the warning symptoms also. Uh, do you have any other question? You want to know about the? Do you know the PopQ quantification system? No.
No, actually, I was embarrassed to ask about it yesterday.
Mm. Mm. The PopQ system, you have got three. I mean, it is a grid system. The C shows the uh, cervix, or and D shows the pouch of Douglas. This is the jar. It shows the gel. It is there inside. We can use even estrogen gel also can be applied along with the lidocaine gel. And patient can be given if she is postmenopausal, she can be advised to use estrogen gel also. Uh, she can have prolonged use of it as far as it is required for her. If she's having any pain during intercourse or like that, if she has any bleeding or ulcer like that, she should come back to the pessary specialist. And then we asked about the PopQ system. No, the anterior wall of the vagina we have from the hymen. We have a point called AA, that is more near to the hymen, that is the point. Whereas BA is the farthest point, that is, it is high up near the anterior, highest part of the anterior fornix. Whereas in the posterior wall of the vagina, we have AP, which is the closest portion, part of the posterior wall to the hymen, whereas the BP is the farthest portion. But when the descent occurs, they will come outside, and if the only the A anterior wall alone is descended, we call it a cystocele or anterior vaginal wall prolapse. Whereas if only the posterior wall is coming down without the this vagina, I mean without the vault descending. Vault means that is the uterus descending. Uterine descent is not there. Then this is called as rectocele, or above that you can have the enterocele, or this is called as posterior vaginal wall prolapse. This is the recent terminology. And if the
Time
uterine
finished
descent is
now.
there,
How we will close the
time is
stage?
over. Okay, I will tell you on another time. It has become very late. Sorry. I will tell with your. I will draw a figure and teach you well. Thank you. I'll give you some strategy links also, and you can have a look. I'll give you written information also. How was the teaching? Do you find it is easy, Hani?
Yes, yes, I find it very helpful. Thank you very much.
Thank you, Hani, for your time.
Thank you.
Thank you so much. Thank you, sir, for your chance, sir.
I will close the presentation and I will tell you why they put these proofs. I will open my camera to tell you why they put a pessary, why they put a jam jar and the lidocaine gel. First of all, I like your introduction, your communication, your frequent asking about my knowledge, asking about if there is any problem in the department. You put the mark of the communication. The allergy was a start point in safety. I will give you all the mark sheet of that stage. So you have asked about most of the important points. I was not happy only about there is some confusion about the PopQ quantification system. And I will tell you how I will perform in that stage. I will close the presentation and open the camera.
Yes, sir.
Okay? Can you see me now?
No, sir.
Okay. Can you see me now?
Yes, sir. Yes, sir.
On the table in front of me, they put, let's say this is a jam jar. Okay? And this is a lidocaine gel. This tube contains a lidocaine gel.
Yes, sir.
And there is a vessel in front of me. Okay? Then he told me how I will know the size. You answered it. But he put the jam jar to teach on it. This is a vagina.
Okay.
And this is the hymen, the opening.
Okay,
and this
sir.
is the vault. And on the jar there was here A anterior and here A posterior at 3 minutes, at 3 centimeters from the hymen. So I will tell him,
sir.
imagine with me this is the hymen of a woman. And this is the uterus removed. This is the vault. Will be point A anterior, and the remaining part will be point B anterior. And this will be point A posterior, and the remaining part will be point P posterior wall. These points are away from the hymen, the imaginary line here, by 3 centimeters. How to estimate the size of pessary? I will do a PV like this. To reach the posterior fornix and here the symphysis pubis. Then I will put a mark here. This mark will be the diameter of the pessary. So I know the size of the pessary, the proper size of the pessary. He put the xylocaine gel to tell him I will replicate. I know to ask the patient about if she have allergy for latex, to have allergy for lidocaine itself, or butadiene, or any washing or any cleansing material. So the proofs in front of you, he puts to use and teach. Okay, my dear?
Yes, sir. Thank you, sir. Nobody has taught me like this. So really, I'm very blessed, sir, to have a teaching from you of pessary. Thank you, sir. Thank you so much.
So I will tell him, I will lubricate the pessary, squeeze it, and put it in the posterior fornix. Then I will put it here above the symphysis pubis. Actually, pessary will work in all kinds of prolapse, especially the vaultal prolapse and the anterior wall prolapse, because it works by stretching the vaginal wall. But for some extent, it does not work with the posterior wall prolapse, as it will come below the pessary. And this is mentioned in the patient information leaflet.
Okay, sir. I'll go through, sir.
Yes, you should, my dear. So now I told him what is pessary. Pessary is a plastic device made from rubber, silicone, or vinyl. Works by stretching the vaginal wall and elevating the prolapsed part, supporting the prolapsed part above the symphysis pubis. Imagine with me, this is the cuff, the vaginal vault, and this is the anterior wall and the posterior wall, and here will be the symphysis pubis, and here will be the posterior fornix or the vaginal wall. Then how to proper the size of the pessary? Then squeeze it, put it, then elevate it above the symphysis pubis, and ask the patient to walk. Why? Because the size of the pessary, if it's small, it will fall. If it is big, it will obstruct the urine.
Okay, sir. Okay, sir.
Okay, my dear. And tell him, can you please tell me? So I teach him what is pessary, what is the indication, what is the complication, what is the allergy, what is the safety point. After teaching, I will tell him the red flag. You should follow the patient. As you said, just the communication and the using of the probe, you should do like what I have done. Okay, my dear?
Thank you, sir.
Let's go for the feedback in an organized manner. You have done very well, but needs to be efficient, my dear. Thank you, Martin. Thank you, Malcolm, for doing this station, my dear. Thank you very much. I will introduce myself the same like my friend Mankam did. Hello, I am Hani, the ST5, or I am Hani, the registrar. No Dr. Ziz, because he is my colleague, and she did this. Hello, I am Hani, the ST5. Can I confirm your name? I came to know that you are the one who wants to know about the pessary. Did you read about it before? Can you tell me why you want to know about the pessary? So I asked about his background. I asked about if there is any problem in the department or no. Are you a right-handed or a left-handed? So I want to teach him.
Yes, sir. Yes, sir.
Okay, it will help also in all stations. If I want to teach him in a forceps, in a ventouse, in a laparoscope, I should know he is right-handed or left-handed. How's everything is going? Can I see? I see that you want to know about pessary. Did you hear about it before? You will find all the department supported. If you need anything, just ask. We'll be aware here. All of us will help. Ask about the knowledge. Ask about the background. And by the end, I will give you the RCOG guideline, or I will give you the POPQ quantification system to read more about this. Here is what we are going to do today. I will tell you about the type of pessary, the indication of pessary, what is the complication, when to remove it, how to follow it, and what's the blower side, and I will give you at the end the RCOG guideline. What is pessary? Pessary is a rubber device, works by elevating the prolapsed part by stretching the vaginal wall. A rubber device that designed to elevate the uterus, the pelvic organ, which is prolapsed, by stretching the vaginal walls. It can be made of latex, silicone, or vinyl. Vaginal pessaries are alternative for treatment. It can be for any stage of prolapse, 2, 3, and 4, and post-hysterectomy vault prolapse as well. There is different size of pessary. The most common one is the ring pessary. How I know the appropriate size? As I told you, I will do BV, and I will measure the distance between the posterior fornix and the back of the symphysis pubis. This will be the diameter of the pessary. What are the types of the pessary? Ring pessary, ring with support, shelf, gel horn, yeast ring. The difference between this and this will be, is the woman sexually active or no? So I will decide the type of pessary. Pessary follow-up will be every 4 to 6 months to avoid infection, ulceration, or neglected pessary. To remove and clean it and put it back or change. Am I clear so far? These are the types of pessary. Ring, ring with shelf, ring with noob, which help in stress incontinence, all these with a sexually active woman. Donut pessary. Space occupying. Cube pessary. Donut pessary inflatable. Gel horn pessary. For non-sexually active woman, which is an old woman not sexually active. There is another special type called the yeast ring pessary, which is a silicone pessary releasing estrogen, which will help in postmenopausal woman. Atrophy. So these are the types of pessary. Again, ring pessary, ring with a shelf, cube, donut, gel horn, all these for sexually active woman, and these for space occupying pessary, which is not sexually active woman. You see here, it will occupy the vagina. Elevate and occupy the vagina. It's not sexually active woman. These are a big pessary, obliterate the vagina. But this one, no, it will not obliterate the vagina. It will be the symphysis in the posterior fornix and above the symphysis pubis. So it can be in a sexually shared or in a sexually active woman. I need informed consent, and you mentioned, and this was a star point in the safety. Allergy and informed consent was a star point in the safety. Indication, and you mentioned, patient refused surgery, unfit for surgery, or awaiting surgery to reduce the symptoms. Complication or contraindication, latex allergy was the star point. Otherwise, the patient will have anaphylaxis because of you. So I should change the gloves, should change the pessary to be latex free. Should ask the woman about, is she allergic to lidocaine, rubber, latex, or even the betadine, the alcohol.
Yes, sir.
Active bleeding will be contraindication. Infection, patient can be followed or no. The patient can come for follow-up or no. Complication will be bleeding, infection, ulceration, and difficulty of removing in a neglected patient. After you put it, you will ask the patient to ambulate for 15 to 20 minutes. Either the pessary is big, so it will cause obliteration. She cannot pass urine retention, or it will fall if it is a small size. So I need error and trial to adjust the pessary. The pessary may fall or the patient may not have urine. When they put the jam jar, I used the jam jar to demonstrate the point of POQ. So I put it here. This is the jam jar.
Yes. Yes,
As I told you, this is the hymen, and here this is point A anterior, and this is point A posterior. And I will squeeze the pessary, lubricate it, and put it here. And after that, put it above the symphysis pubis. Do it, please. Lubricate the pessary from all sides, squeeze it, put it here, introduce it in the vagina under your finger, then put it here and release it to be stretching the vagina and elevating the prolapsed part. It will work on the upper wall to prolapse and anterior wall prolapse. But you see here, it will not work on a posterior wall prolapse because the pessary will be above it. The posterior wall prolapse will go back again. So it will help in vault, anterior wall, but it's less important in the posterior wall prolapse. And now I told him about the POPQ, the anterior point, the remaining posterior point, the hymen, and the vault, how to reduce the pessary, how to remove the pessary. I will remove it by gently hook my finger here, remove the pessary, and clean it, change, or put it back again. Okay?
Yes.
At the end, how do you find, and you covered uses. So, Hani, how did you find or achieve your concern and expectation today? How can I improve my teaching? I will give you the GTG about POPQ and post-hysterectomy vault prolapse. If you read it, if you want more information, I will be happy to discuss with you again. And this was the mark sheet in my exam. Appropriate introduction and closing communication. Ensuring understanding and checks and repeat. Discussion and appropriate clinical level. This was the communication with colleague. Information gathering. Appreciate the liver or what about his current knowledge and background. 1 point. The learning goals and the concern. 1 point. Asking questions. Is right-handed or left-handed? Ask him to repeat. The applied clinical knowledge will be a clinical demonstration. Correctly demonstrate the pessary insertion, removal, the criteria, how to apply, and how to reinsert. The safety point, the risks, the contraindication, how to manage problem during insertion, how to manage complication, when to remove. Okay? And you cover most of these points. Thank you, my dear.
Thank you, sir.
Thank you very much. Anybody wants to do the second station? Unmute yourself and I will give you the 2 minutes. I will put the station and I will give you the 2 minutes. This is your station. You need to teach me about the operative notes. I am an FY1. You have 10 minutes to explain what is operative notes. Review the operative notes I have done. This is an operative notes I wrote for a patient. How to make it better. And give me a feedback and support about this operative notes which I have done. Take your time, 2 minutes, prepare yourself, then tell me what is the importance of the operative note, how to improve my operative notes, how to make it perfect, what I need to write in the operative note, why operative note is important. Okay?
Okay, yes, sir.
Okay, my dear. Okay, Dr. ready?
Okay. Hello, I am Intisar, the ST5, and you?
I am Hani, the FY2.
Okay, hello, Hani. Nice to meet you today.
Thank you, Doctor. Thank you, Dr. Insar.
Hani, for how long are you joining our department now?
About 2 months. I'm a little bit new in the department.
And how the things are going on?
Yeah, it's fine. Everything is fine.
Okay, do you know, do you feel that you are comfortable here in our department?
Yes. Actually, I love it. I love it. Thank you, Doctor.
Okay, and please, Hani, if you have any concern or you need any help, you can call me or any one of my team. We will be delighted to answer any query for you. Okay, Hani?
Thank you very much, Doctor. Thank you very much.
Yeah, Hani, I noticed that you have write the operative note of Mrs. Linda John. You know, am I right?
Yes, Doctor. Actually, the consultant said to me to write it after the surgery. I was an observer there, and
Yeah.
is there any problem with it?
No, I just wanted to know about your feedback about the operative notes. Do you know what is the importance of the operative notes?
Actually, this is my first time. I want to know more about it.
Yeah, sure. And really, you've done a good job, Hani, about the operative note. But if you allow me, could we speak together about your operative note in order to make it more better or until it reach to be its excellence?
Yeah, actually, Doctor, this will be very helpful. Thank you very much.
Okay, Hani, thank you. First of all, the operative note, is really a very important tool because this explains the patient condition when you enter into the hospital and what are the measures that is done for her, and then and what about her case about discharge, and also the plan for follow-up for her. And of course, this will be put in the notes and the file of the patient, and in order to if we want to regain back this information again, it will be available, and it is it's a legal document, or we can say that a medical legal document to know everything about the patient while in hospital. Do you follow me, Hani?
Yes, Doctor. So it's a very important comment to follow the patient and the medical
Yeah.
legal as well. Thank you for highlighting it.
Yes. Yeah, that's why we have to be very precise and very honest when we do the operative notes. Okay?
Okay.
So, what about, let's take your operative note about Miss Linda John. Okay?
Okay.
Yeah. First of all, let's speak about the good things you do in the note. You write the name of the patient, the name of the consultant, the name of the hospital, the date of admission. Uh, um, okay, but in order to make it more better, so that we have to add the the date of birth of Miss Linda John, as well as the NHS number, because this is very important in order to ensure that this is the patient we are talking about.
Okay. I will add here the date of birth and her number. Thank you very much.
Yeah. Yeah, and the consultant name, yeah, you said Dr. CJK, but it's better to be full name, uh, if you please.
Okay. So I will write the full name of my consultant. Thank you very much. Yes, that will be better.
Yeah. Yeah, coming to the second part of your operative note, you did it very well. The patient admitted on and with smaller pregnancy and evacuation and done under general as content remove as well. Okay, uh, 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 what do you think, Hani, if we start this paragraph by writing what actually was the case of the patient on admission? Maybe she was in shock because of bleeding, or maybe she was in a severe bleeding but still vitally stable, or maybe she in need for an immediate interference, by stabilizing her condition and shift her then to the operating theater immediately. So it's better to write what was the condition upon her admission, and especially whether at night, and usually it is more preferable if we mention the actual time she entered to the ER. Okay?
Okay.
And in brief, what are the investigation done for her, and such as an ultrasound, such as, for example, fetal blood count, like that. Then you said that she is molar pregnancy. Yeah, this is very good, but could you define whether it is a partial mole, looks like partial mole, or complete mole by the ultrasound? Because this will be ensured by the histopathology after that. So most probably it is partial or complete mole. Okay?
Okay.
You said that evacuation has been done under general anesthesia. Okay, but please write by whom exactly? By the consultant or just in the presence of the consultant?
Okay.
By ST5, by the colleague who do this or who did this operation. Okay. You said that the content removed and the bleeding stopped and no follow-up. Yeah, okay, this is very good, but the content removed, I mean that the phrases are a little bit need to be completed. Hani, I'm sorry to tell you that. Content removed and sent to the lab for histopathology, because this is very important. Okay? We have to analyze the tissues that had been come out of the uterus. Then you said bleeding is stopped. Okay, very good. If you please, you could say, for example, bleeding stopped. We add anabolic oxytocin or misoprostol, like that, and no follow-up. Actually, this is, I'm sorry to tell you, Hani, this is a very dangerous phrase, because if it is a molar pregnancy means follow-up after. This is really very important. Could you tell me, Hani, why it is very important to follow up after molar pregnancy?
I don't know, doctor. The bleeding already stopped.
Yeah, but if it is proved by the pathology that it is a molar pregnancy, we have to follow up the patient very closely, because sometimes molar pregnancy could turn into cancer.
Oh.
So we have to early to follow up the patient until the beta HCG in her blood descend to 0 level, until to ensure that she is being cured totally. So it is not only the matter of removal of the molar pregnancy from the uterus, but we have to follow up until the whole pregnancy blood, the beta HCG follow up to 0.
Okay.
So we have to say that the patient will be followed up closely by being registered as one of the center, according to whether, Hani, we have 3 centers in UK, one in London, one in Dundee, and one in Sheffield. So according which is nearest to the patient address, she will be registered at that center, where is a highly specialized center to follow up patients who have developed molar pregnancy, evacuated, and they are responsible to take care of the patient and to provide them with the kits of the pregnancy test to be followed up closely and to detect any deviation from normal. That is to say, if the patient going to start to develop any gestational trophoblastic neoplasia or some sort of cancer, so they can early detect it, and the patient will be treated to receive the suitable treatment for her, which is usually according to her score in form of chemotherapy, either single agent or multiple agent. But you have to tell it that you will be followed up at which center and like that. Okay.
Okay.
A patient is stable. Yeah, it is good, but blood pressure plus temperature is fully stable and will be discharged home today after the ensuring that everything is okay. And she also, but Before being discharged from hospital, we have to ensure that the patient go to the contraceptive clinic in order to receive the suitable contraception for her and for her condition as a molar pregnancy. Because part of the follow-up is that the patient should avoid getting pregnant until the period of follow-up ended successfully. So she has to receive a reliable contraception to prevent pregnancy until the follow-up of her has been completed successfully, denoted by the center which is registered for. So so you have to set that she has been referred to, and mention also the date you will come for follow-up at our clinic. Beside that of the center responsible for follow-up of molar pregnancy. Okay?
Time finished, my dear. How we will close?
I'm sorry, sir?
Time finished, my dear. You have passed the 10 minutes. How we will close the station?
Yeah, okay. What do you think about what I'm telling you, honey?
Actually, you updated my knowledge. I need to revise it again, and I will do it again with you, if you please.
Yeah, of course, I will be delighted for that, and I will provide you with the RCOG guidelines about molar pregnancy and its management, as well as the certain links about these centers which are responsible for follow-up of women with molar pregnancy, and I will be delighted to answer any query you have, and if you wanted to come at the clinic, at our clinic, where there is a case of molar pregnancy, so we could discuss it together and about its management. How does it seem to you, honey?
Nice. Thank you very much, Dr. Nissa. Thank you very much.
Thank you, honey. Thank you very much for your time. Thank you.
Thank you. Actually, I like your performance, my dear. I like your way for speaking for your colleague. You did a very good, effective way of communication. Just a few points. At the point of follow-up, you little be mental in it. So try to avoid this. This is very risky. So try to be better than this. Actually, if any patient who have a molar pregnancy, followed up by the PSG to avoid turning into malignancy. Otherwise, you did perfect, my dear. How?
Thank you, sir. Thank you for giving me this opportunity. Thank you.
My dear. How I will do this station to master it. Let's see how I will do this station. You did very well in putting the operative note on the template, but you didn't highlight for me the template. I want the template first of the operative note. Why it's important, you mentioned. It should be written when it should be written. Why it is important? Because it's a continuity of the care between the operative team and the one who will follow the patient, the inpatient team, the nurse, the midwife, or the GP. What is the scheme, the template which I will fill? It should be a computer-based or a paper-filled, a document. I will give you the unit performer. I will give you a samples from the unit to read and to practice with it. I will tell you a lot of feedback. Actually, I prepared this station very nice. Hello, I am Hani, the ST5, and you, I am John, or I am the ST1. Nice to meet you. I came to know that you want to know about the operative notes. Is that true? Yes. Can you tell me why you want to know about operative document or operative details? I did it yesterday, and I feel that my consultant is not happy about it. Don't worry. This was our issue. All of us was like this. I will tell you how to do it and how to make it perfect. Everything is fine in the department. I can see that you did the operative notes for Mrs. Linda, as you said exactly. Let's make it better and more informative. I'll tell you how to bring it or how to use the unit performer to familiarize yourself about the unit performer. I will also provide you by a useful article or the Green Top guideline about molar pregnancy. If you have any question, please don't hesitate to ask me at any time. It's okay. Avoid blaming. Avoid you should. It's better rather than say it's better or make it more informative. And you managed to do this, my dear. Check her background and you managed to do it. About writing notes, about the management of molar pregnancy. Tell the importance of the operative notes and how a good one must look like and apply what he have done on the template. Let's see how I will do this. First of all, an operative notes is essential because it ensures the continuity of care between the operating team and other tools. And it is a medico-legal document. And you managed to say this for some part of the consultation. All surgical trainees should know about the operative note. It should be through a framework. Better to be computer types or a checklist, and I will fill it. All surgical trainees should know about it. The operation note. Here we will present a framework how we will document the operation document or the operation note. The principle can be also applied on any surgical procedure. Note should be completed immediately after the operation by a one who was in the surgery, in the operating team. Why? It can be handwritten or a typed, a template, a computer-based, or a performer. Why? It will be only filling the defect, so you will not miss anything. Am I clear so far? A template-based operation note to standardize it, the layout and the post-operative instruction. It will be easy to remember and easy to fill. Am I clear so far? Yes, that would be perfect. It should accompany the patient from the theater to the recovery and to the ward, as it is a continuity of the care between the operating team and the other department or the other part of the multidisciplinary team. Okay? Okay. The operation note should contain the patient name, date of birth, hospital number or NHS number, the time of admission, the operation, the name of the operating surgeon, the consultant, the anesthesia, the assistant. It should also include the operation itself, specify the operation itself. He wrote ERPC, avoid abbreviation. It's not an ERPC, it's suction evacuation. It is not evacuation and removal of the product of conception. It's called suction evacuation. With mention the site, the location, the appropriate, along with the method of anesthesia. And you mentioned it was under general anesthesia. Details of the operation, preparation, before, how I will prepare the patient, the position, the lysotomy, or is it a supine position? Additional procedure may be needed, such as catheterization, antibiotic prophylaxis may be needed. Remember that the operation note can be broken after that into 5 main parts. The incision or the approach, it was vaginal in our case. In other notes can be changed. Operative notes for a surgery, operative notes for a cesarean section, so the approach for the surgery itself. The finding during the operation, the operative finding should be documented, including the pathology, the sample, specify if there is any deviated pathology or an anatomical deviation. The procedure in a step-by-step, the cervix was opened, dilated, suction, a cannula was introduced, the patient was cleaned and wrapped and sterilized, and we put a catheter to evacuate the bladder by manual examination have been done. The cervix was open, suction cannula have been introduced, and the image have been timed or have been put it into the PACS system. After that, any complication happened. Unexpected procedure happened. Perforation, bleeding. If there is any blood loss, significant blood loss, any nerve injury, any problem happened during the surgery, actually the surgery was smooth. I need to document this. The operative notes will be accompanied to the patient, and the GP will know, and the ward will know, so I need to write if there is any problem in the procedure. If there is any closure steps, the fascia, the skin, or in vaginal, I will not do any closure steps. Just by manual examination, compression, cleaning the patient, checking that there is no bleeding. And the post-operative instruction, which I need to highlight the post-operative care, the venous thromboprophylaxis, the pathology for microbiology or lab to analyze it, the histopathology sample, the antibiotic, the multidisciplinary team, the physiotherapy if needed, the dressing if needed, and how will be the plan of care after that. If there is any intraoperative image, it should be documented in the PACS system, which is the picture archiving and communication system together, because if the patient needs to know about the details of the operation, she will have all the documentation. Then the document should be signed by name, by your number, the grade, the GMC number, and the date of the operation. It will be like this. This is a template which is provided by the WHO. The good surgical notes will look like this. The date, the time, is it elective or emergency, the name of the surgeon, the assistant, the anesthesia, the operative documentation, the preoperative diagnosis, complication or additional procedure were done, any issue removed or altered, any procedures given, the closure, the anticipated blood loss, antibiotic prophylaxis, DVT, detailed about it, and all this should be fulfilled in the notes. And after that, let's apply what you have done on this template. That's what you have done. Okay, my dear? Clear, Dr. Antisar? Are you hearing me?
Yes, doctor, I am hearing you. Thank you very much, sir.
Thank you, my dear. This is how to make it informative, how to make it safe, and how to be a structured, organized approach. I hope that you enjoyed the session today, and I will see you in another session, inshallah.